Jan Chan is our next speaker. She works as a dietitian practice leader at the Burnaby Hospital and also works with patients on the acute care for the elderly ward and the neonatal intensive care unit. For the past 12 years, she's worked in a variety of areas from medicine, surgery, intensive care, neonatal, etc. She's also recently completed her master's in rehabilitation sciences at UBC. Her research project was a pilot project for protected mealtimes at Burnaby Hospital. Jan will present on how to effectively collaborate with other health professionals and how she contributed to successfully implementing the protected mealtimes. Welcome.
Thanks, everyone. My focus today is the implementation piece of my study. If anyone wants to hear more about it, please email me. Next slide. I'll just start with a little bit of background. I know a lot of you guys know these statistics, but 40 to 69% of patients are malnourished in hospitalized patients. And these stats are quite similar to those in the UK and also in Australia. Malnutrition increases morbidity and mortality. In our patients, it increases immunity, muscle strength, respiratory function, and delays wound healing. And all these increase the likelihood of infections and complications in our patients and leading to increased health demands and length of stay. So the Keller group in 2011 looked at what barriers there are to eating in hospital, and they found that almost 35% of patients miss their meals due to medical procedures, and almost 42% are interrupted during the mealtime. And almost 39% are disturbed by noise, smells, and activity. So what is a protected mealtime? It's a patient-centered approach that ensures patients receive the opportunity to eat without any unnecessary interruptions during the mealtime. So this was it was first initiated in 2003 by the UK. They've actually mandated it across the country, and if they don't follow this on the wards, they actually get fined, which is quite a shocking occurrence. And what the CMTF, the Canadian Malnutrition Task Force, has also recommended it to prevent malnutrition in hospitals. So some of the activities of a protected mealtime include asking nurses to take their breaks outside of the protected mealtime, avoiding non-urgent transfers, and also non-urgent or meal-related tests or therapies. So for example, PT, OT, physicians coming into the room and asking patients regarding their medical or doing their rounds and therapies. So we ask them to do this all outside of the mealtime. And then also having their hands washed prior to mealtime, clearing their bedside table so that there is a space for their meal trays, and assisting patients with feeding and containers. As most of you who have worked in a hospital know that it's quite hard to open all the different containers on the meal tray. And also documenting intakes. So I did a literature review in fall of 2012 and 2013, and we found that there was actually very little evidence around the protected mealtime, and this actually was really shocking because knowing that the UK just mandated this across the country and there was no research. Overall, we only found 3 quantitative published articles, 3 abstracts, and 2 qualitative studies. And when you review, I can't get into the literature today, but overall, the results were quite variable, and the main reason is depending on how strong their implementation plans were, it really affected or limited their project. So, and again, there was no randomized controlled studies, and there was no studies done in Canada. So the purpose of my study was to determine whether the protected mealtime would improve patient mealtime experience and also patient care in our older adult population at Burnaby Hospital. So we piloted a, sorry, slide. Next slide. Next slide. So we piloted, sorry, one back. Thank you. So we, one back. Oh, no, back. You're going forward. Yeah, thank you. So we piloted the protected mealtime for 4 months between February and June of 2013 and on our 8th ward, which is a 35-bed ward at Burnaby Hospital. We developed a protected mealtime policy, and we evaluated using a pre and post observational audit and also a staff administered questionnaire afterwards. So one of the biggest challenges, as I've mentioned, is just changing the way staff work in a hospital. So it was a real big culture change, and also communicating and educating all staff. So as you can see, education involved everybody who could possibly come into the ward. So that included nurses, physicians, allied health, support services, including laundry, maintenance, food service, anybody, volunteers, medical imaging, lab, and just anybody who would come onto the ward. Next slide. So we created an interprofessional planning committee, and we did this about 1.5 years before the actual pilot. So it was quite a long planning because we really didn't know where we were starting. So it included educators, allied health, like our SLPs, our educators, nurses, and some of our rehab staff were also, and dietitians, of course, were included in helping to create the policy and also create the educational plans. All that stuff is done, and just moving forward, it's been a lot easier to implement. And then again, we also engaged our staff. So once the pilot started, we actually asked the nursing staff, how can we make these changes to make it easier for you? So they gave some great suggestions. Okay. So as I mentioned, we used every type of education mode, mediums possible. We used pamphlets, group huddles, one-to-one conversations, formal presentations to physicians and other groups in the hospital, and also posters and flyers and emails, everything. So some of the results I'd like to share is that we did find a significant decrease in our interruptions from 31 to 13, and also total number of patient interruptions. And the reason why we had to differentiate that is because many of the patients were interrupted more than once during mealtime. And then, as you can see, our hand hygiene improved dramatically from 0 to 23. And this is actually quite usual. We tried auditing other wards, and I know most healthcare providers are really conscious about washing their own hands, but we really haven't taken that next step to start washing our patients' hands. And they often forget when they're lying in bed that they also need to wash their hands to prevent that whole oral mouth infection barrier. So some of the sources and reasons for these interruptions included nurses, housekeeping. Those were our main ones. And then for reasons, it was mainly elective procedures. So anything, like it could be from IVs to changing of skincare to and then drugs. Also medical reviews were also some of the typical reasons. So when we asked our staff what they thought about the protected mealtime, Overall, we got quite positive review, which was quite shocking because we did change their whole work routine around. They did feel that they had adequate time to, patients had adequate time to eat, that there was decreased interruptions. They encouraged staff, they had more time to encourage staff to eat, and also the whole ward was a lot calmer, and just the whole environment was a lot quieter and improved. And then when we did ask about whether their work was altered in any way, overall we did get quite positive feedback that they did feel they had more time to assist patients and wash their hands. And other questions that I had that I don't have on the slide is whether they had enough time to do their other work, and most people said they did, so it didn't change their work routines as much as we thought it would.
What's the average time spent for a meal time?
It was an hour.
Yeah, a full hour.
Yes, a full hour. So in conclusion, we felt that this did improve patient mealtime experience and patient care, and it was an effective approach to improving nutrition therapy in hospitalized older adult patients. We also felt that it was, because it was a focused designated mealtime, we were helping to reduce malnutrition in our hospital patients. And again, that whole system-wide education support is really needed in order for this to be successful. Okay. Some of the limitations of this study was it was a very small study, 35-bed ward, and we did have limited data about the source and reasons of interruptions, and that was the limitation of our audit tool, because I used one that was previously used in another article. And we did not compare intakes, which is something that we would love to do in future studies, and also there was quite a low response rate from feedback from stakeholders. So some of the tips, if anyone's interested in doing this on your wards, is try to be flexible during the education. You'll get a lot of staff that at first they might be sort of apprehensive, but overall, when I tried to focus on the patient when I was talking to them, if you were a patient on the ward, how would you feel? And everyone sort of said, I want to eat my meals when lunch comes around. So I think everybody understood, even physicians said, I get it. I think we need to do this. So we got quite a lot of support going that route for the education. And overall, a team approach. I had a very supportive team. The managers were very supportive in altering all their schedules and everything, so it worked out very well. And then also open communication. We engaged our nursing staff and tried to get their opinions on how to make this work, and I think they were really motivated to make these changes because they were involved too, and it was for the betterment of the patient. Okay. And just future implications, we are continuing the protected mealtime on ACE, and of those ones that had more interruptions, we are doing more education to those departments. And as of this week, or as of next week, we are starting our neuro stroke ward at Burnaby Hospital, and I know some of the other Fraser Health hospitals are also interested. And again, more research is needed in this area, and a larger study would be nice. And questions?
So we've got about 5 minutes or so. We're going to open it up to general questions involving both of our education sessions. So I would just go ahead now and open up the floor and raise your hand and fire away. Yes. Is this continuing this program now after research is done?
Yes. Yeah, like right away, I talked to the manager and we decided to continue on because it was working so nicely, and everything seemed to be working really well, so it's kept on. And we've had a few visitors come by, like Vancouver Coastal, and it was still happening, so it's still going well. Yes, so as I mentioned that we are expanding to our stroke unit as of next week, and I know some of the other wards are interested in other hospitals too in Fraser Health.
Okay, I think I saw a question in the back. Two questions. Are you planning to work with dinner at all? And secondly, are you going to start doing tray audits or waste audits?
So, okay, so we haven't expanded to the other meals because in the UK they do all 3 meals. And your second question was whether. Yeah, so we did do tray audits. The first we did it, but it wasn't part of the study, and we only did one. So, and that was because our managers really wanted to know whether the food was eaten. And we did see an improvement, but it was only 1 tray audit, and we tried to keep it on the same menu date. So, so it was the same food, but it was an improvement.
The UK group, because we have been doing it for 10 years, have they had any sort of like, not qualitative, but looking for more quantitative sort of data and data?
So of those few studies, they did do some interruption studies there, and just some had improvements, others didn't, depending on how well it was implemented too. But they haven't done like a whole country sort of mass. It's usually per hospital, and I don't know if it's the way they how they're funded or whether one hospital talks to another hospital. So I don't really know how